Oh, thank you. I am Shinya Tajima, Japanese pathologist. Can you hear me? 小さくなっちゃった。
Yes, we can.
Okay, thank you. Can you see my slides?
Yes, doctor,
Yes.
we can see your slides.
Thank you. Now I would like to presentation about intraductal papilloma and related lesions. No conflict of interest. I am Shinya Tajima, graduated Keio University and ran St. Mariana University, and I am pathologist and radiologist. I am now working National Hospital Organization, Shizuoka Medical Center, at the foot of Mount Fuji. Very beautiful. My wife is radiologist and especially gynecology. And I am photographer and good at peeling. Preface. Breast cancer is world-threatening disease. Hence, early detection of breast cancer is important, and also excluding benign lesion correctly is important matter. Introduction. Breast benign papillary lesion is mainly intraductal papilloma, IDP, and malignant is ductal carcinoma in situ, DCIS. Comment. We introduce IDP and related lesion because in surgical pathology, correctly diagnose benign and exclude malignancy is very important. However, in fact, it's too difficult and challenging in especially core needle biopsy, CNB. Here we will present some intraductal papillary lesions of CNB. Let's consider the answer. Middle magnification. What is the diagnosis? What is the diagnosis? This is intraductal papilloma. The luminal cells are not uniform without atypia and lined fibrovascular core. Not uniform means benign in breast. Next, middle magnification. What is the diagnosis? Hint. CK14 plus P63 immunostain. ER, estrogen receptor. Answer, intraductal papilloma. CK14 is mosaic pattern and ER is heterogeneous. In this case, the tissue is fragmented and it is difficult to determine benign or malignant. Low magnification. What is the diagnosis? Middle magnification. What is the diagnosis? Hint. CK14 plus P63 immunostaining. Estrogen receptor. Positive. Synaptophysin positive. Answer is solid papillary carcinoma in situ. Composite cells have uniformity with atypia. In breast lesions, uniformity indicates malignancy. And synaptophysin is positive, so neuroendocrine. So solid papillary carcinoma in situ. Low magnification. What is the diagnosis? Middle magnification. CK14 plus P63. Estrogen receptor positive. Synaptophysin negative. ductal carcinoma in situ, non-comment type. CK14 is negative and estrogen receptor demonstrate homogeneous, diffuse strongly positive. Hence, this is malignant and ductal carcinoma in situ. Low magnification, even if fragmented and difficult, we have to diagnose. What is the diagnosis? High magnification. What is the diagnosis? CK14 plus P63 immunostaining. Estrogen receptor. Answer, intraductal papilloma. CK14 is mosaic pattern and ER is heterogeneous pattern. This is benign pattern. Results. From the above cases, breast papillary lesions are sometimes difficult in HE section and exhibit broad range. So, immunostaining may be helpful. Our problematic cases, here we will present new concept of papillary lesions resembling IDP. These lesions exhibit completely lacking of myoepithelial cells, but thought to be benign. In the past, lacking myoepithelial cells is thought to be invasion and means malignancy. Utility of ER, CK56, MAC3, and P63 is important, and Furia et al. Reported differential index to distinguish between benign and malignant. Sadik et al. And Selfun et al. Reported that cyclin D1 may be useful for discrimination of benign versus malignant. We evaluated cyclin D1. T67 can be used to determine the grade of malignancy and for prognostic evaluation. We performed T67 staining. We use the differential index using OLED score. DI-ER plus MAC3 per CK56 plus P63 plus 1. Cutoff was 1.0. Less than 1.0 were classified as benign. Clinical manifestation. Case 1, a 68-year-old woman had an abnormality, so admitted a hospital, and malignancy was not excluded. So operation was done, and the patient was followed up for 62 months, over 5 years, with no evidence of disease. Case 2, a 44-year-old woman felt a palpable mass and admitted to our hospital, and malignancy was not excluded. So operation was done. The patient was followed up for 74 months, over 5 years, with no evidence of disease. Case 2, comparatively low echoic mass with blood signal is seen. Pathological findings. Case 1. HE section showed epithelial papillary proliferation with inverse nuclear polarity, absence of nuclear atypia lined by a fibrovascular core, and lack of myoepithelial cells. Myoepithelial marker was negative. And total OLED scores for ERCK56, P60, MAC3 was 0, 8, 0, and 4. Hence, the DI was 0.44. This is benign. Cyclin D1 was 0%. This is benign. T67 index was less than 1%. This is benign. Case 2, differential index was 0.67. This is benign. Cyclin D1 was 70% weak positive, and T67 index was 0%. This is benign. H low magnification view. Intraductal papillary lesion is seen resembling IDP. H high magnification. Nuclear inverse polarity is seen. This is basal, and this is apical. Nuclei is pointed luminal surface, and this is basal surface, and nuclei is pointed luminal side. This is a distinctive feature of our tumor. Calponin completely lacking myoepithelial cells is seen. Case 1, case 2 also ER negative, CK14 focally weak. Hence, malignancy or benign is not concluded. Then we tried differential index cyclin D1, T67. Estrogen receptor, case 1, 0, case 2, 0. CK56, case 1, 8, case 2, 2. P63, case 1 and case 2 are 0. MAC3, case 1, total score 3. Case 2, total score 0. Cyclin D1, case 1, 0%. However, case 2, 70% weak positive. Mi1, T67, case 1 less than 1%. Case 2, 0%. Results. These two lesions are considered to be benign. All mentioned above are special feature of nuclear inverse polarity papillary lesion lacking myoepithelial cells. In this time, we evaluated Mucin immunostaining. Mucin immunostaining demonstrates accurate diagnosis between benign or malignant in the breast tumor. MAC staining was done. MAC1, case 1. MAC1 positive pattern is not cell wall staining, but apical pattern. This means benign. Case 2, MAC1 apical staining is seen. This is benign. MAC2 of case 1 and 2 completely negative. This is benign. Both MAC4 are completely negative in case 1 and 2. This means benign. Both MAC5AC are negative. This is a usual pattern. Both MAC5B, which detect early cancer, are completely negative. I think benign. Both MAC6 are completely negative in case 1 and 2. This means benign. In the viewpoint of MAC immunostaining status and taking into consideration of follow-up interval, nuclear inverse polarity papillary lesions lacking myoepithelial cells are thought to be benign. However, lacking myoepithelial cells are and not invasion. These results are unique, interesting, and new knowledge. Future comments. In the future, the report of breast lesions lacking myoepithelial cells which behave as benign will be increased, and unnecessary operation will be decreased. This is useful knowledge. By the way, these lesions of the name of nuclear inverse polarity papillary lesion lacking immunoepithelial cells is too long. Then I want to give it the name Tajima tumor. Thank you for your attention. Thank you very much.
Thank you for your speech, Dr. Shinya Tajima. So we really loved your talk on Tajima lesions. So
Thank you very much.
yeah, you're most welcome. So it is open for discussion. If there is any doubts, yeah, please come forward and ask Dr. Shinya Tajima.
Hello, I have a question, if I may.
Sure, ma'am, you
Okay.
can please ask.
Yes, thank you for a nice presentation, Dr. Shinya. I was wondering, because you really summarized it very finely, so it could be that I missed it, but how was it? Did you see any Gene 1 or any other lesions? Was it always just, like those that had basically the clinical matching with the HPV positiveness, but we know that HPV positiveness gives additional lesions. Have you observed any of those, or did you exclude them? May I ask?
Oh, thank you. I think human papilloma virus, HPV, may be associated with breast tumor, especially breast cancer. I think so. Thank you for your question.
Okay, thank you very much.
Thank you.
So anyone else are ready to ask questions to Dr. Shinya?